Welcome to this podcast from the Medical Journal of Australia. My name is Sam Hunt, the MJA's News and Online Editor. Today we are discussing cardiotoxic cancer medications, with a new study finding more than 1 million Australians have been exposed to potentially cardiotoxic cancer medications. My special guests worked on the research and are with me now. Dr. Benjamin Daniels is a Senior Research Fellow at the Medicines Intelligence Research Program at the School of Population Health at the University of New South Wales, Sydney. And Dr. Maria Aslam is a Staff Specialist Medical Oncologist at Maitland Hospital. Dr. Daniels and Dr. Aslam, thank you so much for joining me today.
Hello, Sam. Thank you so much.
Hi, Sam. Thanks for having us.
Let's start by talking about cancer medications. Cancer medications are becoming more effective and more complex, but Dr. Aslam, they also carry risks for cardiovascular disease.
Yes, absolutely. So there's now a huge range of cancer medicines that are used every day in the clinic. And yes, we are seeing they're becoming increasingly complex. In the past, there was predominantly chemotherapy and endocrine therapies, but now we have all sorts of drugs like immune checkpoint inhibitors and targeted therapies and antibody drug conjugates. And really, with each of these, there's some level of adverse cardiovascular effect. In some cases, it's very transient and treatable, like arrhythmias or QT prolongation, but other ones are actually fatal in the short term. So, for example, we recently started to recognize myocarditis as a complication of immune checkpoint inhibitors. There's also other toxicities that are chronic and quite subtle initially or subclinical, and they really manifest years down the track after people have stopped their treatment. So specifically things like heart failure or ischemia, we might not see that when we're actually treating people with these cancer medicines, but into the future, it can definitely affect quality of life and functioning and healthcare costs for patients as well. Another thing we looked at for our study was the indirect effects of these cancer medicines, because we know a lot of newer medicines can cause things like hypertension and hyperlipidemia, which change someone's metabolic profile and are more likely to cause cardiovascular disease as well.
And Dr. Daniels, there is increased survivorship amongst people who have had cancer, with people living longer.
Yeah, that's right. The latest cancer data report published by the Australian Institute of Health and Welfare, that showed that 5-year survival for all cancers was around 70% during 2015 to 2019, and that's up from 53% in 1990 to 1994. So that's quite a substantial increase over the past 30 years. In our study, we didn't look directly at survival, but we certainly saw it indirectly in our data, where each year we saw more people living with previous exposure to one or more of these, potentially cardiotoxic cancer medicines. And our study ran from 2005 to 2021. So that's 17 years of observation and, steadily increasing each year with previous exposure. That's obviously good news, right? People with cancer are living longer, and cancer medicines have, played a big role in that outcome. But, many of these treatments, as Mario was just saying, can increase a person's risk for adverse health events, particularly cardiovascular events, and they can be acute events that happen during active treatment, but they can also cause damage that won't show up until much further down the line. And there's been some recent research that's found for some patients, cardiovascular mortality may actually be greater than cancer-specific mortality for people who have had cancer in the longer term. It's definitely good news, increased survival, but it creates a situation where you have to keep an eye on other non-cancer conditions.
And let's turn now to your research published in The Lancet entitled Prevalence of Australians Exposed to Potentially Cardiotoxic Cancer Medications, a Population-Based Cohort Study. Dr. Daniels, can you talk me through why you chose to study this and what you set out to examine?
Sure. So our study, it followed on from some previous work done by two of our co-authors, Dr. Marina van Leeuwen and Professor Claire Vidich, both also at UNSW. And they published a systematic review a few years ago now, looking at the evidence for cardiotoxicity associated with gene-targeted cancer therapies. So that was a great piece of work they did. And within the Medicines Intelligence Research Program, or MedIntel, where I'm based, we already have a dedicated program of work around cancer and cancer medicines. We decided to kind of go bigger with that systematic review and try to understand the scope of this potential issue of cardiotoxicity associated with cancer treatment. For instance, it's already known that certain cancer medicines, such as anthracyclines, come with risk for serious cardiac harm, but we didn't really know how many people might be exposed to those medicines, or other potentially cardiotoxic medicines. So establishing a baseline we thought was a good first step for future research, but also potentially for health system planners who might have to think about how this might impact the wider Medicare system.
And let's turn now to your findings. Dr. Maria Aslam, can you talk me through what you found?
What we found was that more than half of the people treated with cancer medicines in our study were dispensed a potentially cardiotoxic cancer medicine during our study period. This represents over 1 million people when we extrapolate it to the wider population. We found that the prevalence of people with exposure to a potentially cardiotoxic cancer medicine alive in each year increased substantially over that 17-year period with no sign of plateauing. And one interesting thing was that the rates were much higher in females than in males. And we did actually dig into that a little bit to see what was behind that. And we found that it was mostly breast cancer medicines, so things like anthracyclines and HER2 agents and endocrine therapies. Endocrine therapies are actually interesting as well because they're amongst the most frequently dispensed medicines in this population, but they have a mixed effect. And the true cardiovascular toxicity of them is not exactly clear cut. So, for example, tamoxifen is usually included in lists of cardiotoxic medicines because there's an increased risk of thromboembolism. But in fact, the overall weight of the evidence is that it's cardioprotective or cardioneutral, other than that thromboembolism effect. And similarly, with aromatase inhibitors, a lot of the data around hyperlipidemia and other cardiovascular risks are really in comparison to tamoxifen rather than to placebo. So it's not exactly clear how cardiotoxic they truly are and whether that result might be influenced by these drugs that are used so often. So we did a sensitivity analysis excluding these drugs, and we did find that actually the numbers of exposure for women was closer to men once you remove those breast endocrine therapy drugs.
And Dr. Daniels, what else did you find?
Perhaps an unsurprising finding was that the prevalence rates for people with prior exposure to a potentially cardiotoxic medicine were the highest in older age groups. Cancer is a disease primarily of advanced age, so we would expect older people to be being treated for it more. The rates were highest in those 75 years and older and lowest in those under 30. It's also maybe important to note that between 2005 and 2017, as a bit of context, new cancer medicines were continually coming to market. Past 25 years, particularly around gene-targeted therapies, has been massive for new treatments coming to market. So it's a situation where you have more people surviving longer, you have more treatments than ever before in history. So there's more opportunity to be exposed to these medicines as well. Perhaps most interesting from a long-term care perspective, we also looked at the prevalence of people who were alive 5 and 10 years after that first exposure to a potentially cardiotoxic cancer medicine. While those rates were a bit lower than 1-year prevalence estimates, they behaved in the same way. They increased essentially linearly each year. So, that increased survivorship is showing up there. We're seeing, more and more 5 and 10-year survivors that have a prior exposure to one of these medicines. I found this kind of interesting just as someone who investigates multiple medicine use and polypharmacy. Most people were only exposed to one potentially cardiotoxic cancer medicines. The rates for people with exposures to 2 or 3 cancer medicines were essentially very close to each other and quite low.
And let's turn now to the implications of your findings. Dr. Aslam, there appears to be a growing need for cardio-oncology models of care.
Yeah, absolutely. So we're increasingly recognizing that this is an important issue and it's part of the overall care for cancer survivors. And it's such a specialized field. It's only recently really taken off. So there's still a lot of variation around the country in the level of care people can receive. And Australia is a huge country. So people living in rural areas and regional areas will have different access compared to people in cities. But where I live in Newcastle in New South Wales, for example, we've we've got a really amazing initiative, which is a cardio-oncology specialized clinic. And I've been referring patients there for a couple of years now. And so basically what they've implemented is a cardio-oncology clinic, which is co-located with oncology services. And that clinic is run by a nurse, a cardiologist, and a cardiology fellow. And what they essentially do is early detection, risk management, see the patients that we have detected already are starting to have problems or are maybe higher risk, and then provide a plan for them. So education, lifestyle, and pharmacological interventions. This is really something innovative and definitely not available everywhere at the moment. But I think looking into how to make that practical in other areas, and there's definitely a lot of research and other work going into this currently.
And to follow on from that, it sounds like there is a need to translate treatment recommendations into long-term routine care.
Absolutely. We want to take that information out of these like interspecialty like silos. So basically we want that information to move from cardio-oncology clinics or even oncology clinics to general practitioners who will be looking after that patient for many years after we've discharged them. But that information has to be conveyed. And so one of the things our GP colleague had suggested was Joel, who worked with us on this, had suggested that routine correspondence should actually provide that information in an accessible way for GPs about what monitoring is required, what referrals are required. And I think as this space grows, I think that's definitely going to be helpful. But even more than that as well, we need really defined roles for each person in this. So the GPs and also for non-GP specialists and for patients as well for self-management, we need care pathways so that that information is not something you have to hunt for in a 300-page guideline. It should be easily available.
And you mentioned something very interesting in your piece, that GPs may only see about 4 people a year who may have a terminal cancer diagnosis, which means that cardio-oncology may not necessarily be at the top of their mind.
Yeah. I mean, even for me as a practicing oncologist, it takes a huge amount of effort to be across all those medicines. It's just so specialized. And it's not effective use of time for GPs to need to know all that information. They may want to prioritize their CPD hours for things that are important for them. And so finding a way to make that accessible, definitely.
And this is an evolving area of research. What are the next steps?
Yeah, I guess as a researcher, my first thought is in the research, and I think we need more like implementation research around this, particularly between a cardio oncology clinic and a GP. Because yeah, GPs have to deal with so many things. As you say, they might only see 4 people. I don't have the solution. We need to figure out how that bridge is built to ensure that long-term care.
I do agree with you, actually. So, implementation research around this is really important, and it is actually currently happening. It's just that this is such an emerging field. We've only recently had recommendations that have been more of a consensus that people are going to adopt that. And moving forward from that, there's now some quality indicators that have been produced as well. And I think the next step also is implementation projects looking at what might be an effective way to provide that service. I think that's still a topic of research. I don't think we're quite there yet.
And Ben, a question for you. Clearly, this is an issue that isn't going anywhere because the baby boomer generation has entered the age group that's highest at risk. It's going to be something that becomes even more prominent.
The baby boomers were the largest generation, in the history of the Western world, I suppose, and probably in Australia's, European history. I think, yeah, the AIHW put out a report that said, I think in 2020, it was like 1 in 6 people are over 65. And if you think, cancer risks kind of become more relevant from your 50s perhaps, so it's a larger proportion that are in that cancer risk area, and that's only going to grow for the next 5 years. I think AIHW project that the proportion over 65 will be 1 in 5 in less than 50 years. So cardio oncology is really, I think it's only going to grow in relevance from here.
And Dr. Aslam, what would you like to see happen?
The only other thing I was kind of thinking about looking at cardio-oncology and how it fits into the overall survivorship plan for patients. I think survivorship in general, there's so many different parts of that for people in terms of just their overall health. And cardio-oncology plans need to be integrated in some way with all those things. I find in oncology clinics, it's very busy. And, sometimes we're talking about fertility, sometimes we're talking about neuropathy, and we may not always get to each part of their survivorship care. And so I feel strongly that cardio-oncology needs to be incorporated into survivorship care plans, and we need to have really robust survivorship clinics and plans for people.
Dr. Aslam and Dr. Daniels, thank you so much for joining me today.
Thanks, Sam.
Thank you for having us.
My special guests have been Dr. Benjamin Daniels and Dr. Maria Aslam. Dr. Daniels is a Senior Research Fellow at the Medicine's Intelligence Research Program at the School of Population Health at the University of New South Wales, Sydney. Dr. Maria Aslam is a Staff Specialist Medical Oncologist at Maitland Hospital. You can read their Insight Plus article by clicking the link in the description of this podcast. You can find more of our podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for joining me.